Good evening, everyone. Welcome to Master Classes in Critical Care Medicine from Yashoda Hospitals in association with the ACUTE Hyderabad chapter. So today's case for discussion is acute exacerbation of COPD. To take the case, we have senior professors as examiners today. Dr. Ashfaq Hasan sir. He was ex-faculty from Care Hospital and present professor and principal of the Deccan Medical College, Hyderabad. And another professor, Dr. Anirban Hom Choudhuri. He is active member of IDCCM and professor in intensive care medicine and anesthesia from Pant Hospital, New Delhi. To students who are going to present the case are Dr. Shiva and Dr. Rajesh. So over to you, sir. Dr. Ashfaq sir and Anirban sir.
Thank you so much. And I thank Dr. Venkat and all your wonderful team. And it's my privilege to be here sharing the stage with Dr. Anirban. Maybe if Dr. Anirban agrees, maybe we can discuss or comment point by point as the protocol has been so far, and instead of talking at the end. What do you say, sir?
Sir, let them start the presentation, then we will walk along with them.
Yes, exactly. So, Dr. Shiva, thank you. And please introduce yourself, and then you can go ahead with the presentation.
Good evening, everyone. Now, my colleague Rajesh will present the case. Rajesh, please unmute yourself.
Shall I start? Am I audible?
Yes, please go ahead.
Good evening, everyone. I am Dr. Rajesh, doing the first year DNB Resident in Yashoda Hospitals, Secunderabad. First slide. Today we are going to discuss a case of acute exacerbation of COPD. A 67-year-old female resident of Hyderabad presented with chief complaints of cough with expectoration since 3 days, shortness of breath in 3 days, and fever 47. Next slide. History of present illness. Cough since 3 days, initially associated with white mucoid sputum, which increased in severity over 3 days, with increasing amount of sputum, non-swollen swelling, not blood stain, with no postal or diurnal variation. Shortness of breath since 3 days, initially MMRC grade 2, aggravated to MMRC grade 4, not associated with wheeze, not related with nebulization. Fever 5 days ago, which is intermittent, not associated with chills, related with medication. No history of chest pains, palpitation, swelling of feet, decreased urine output, burning, ulceration, or abdominal discomfort. Next slide, please.
So can we stop here, Dr. Rajesh? Maybe
yes,
we can just finish this thing. So we'll be trying to ask you at almost every step the significance of whatever your historical or your physical findings as you reread them. So I just wanted to ask you a very basic question. What do you mean when you say that the patient is getting expectoration or no expectoration? What is the clinical significance of the diagnosis? I mean, I'm asking it at an elementary level. In a critical care situation, when a person is given a history of expectoration or not given a history of expectoration, how would you kind of point your way towards a particular group of differential diagnosis there? I hope my question is clear.
Differentials of cough with expectoration and cough without expectoration.
Yes. So let's focus on the expectoration, because there will be a dry cough and there will be a wet cough. Now you have a person who's been giving a patient who is breathless, and this patient is also giving a history of expectoration. So is there any particular area that your mind goes towards in terms of localizing the pathology?
Yes, cough expectoration localizes to respiratory symptoms.
Respiratory symptoms.
Predominantly respiratory.
Which part of the, right, but which part of the respiratory system can you localize? For example, if you have a person with pulmonary embolism, do you expect expectoration?
No, sir.
No. So the vasculature is not something that you're not thinking about. Pulmonary vasculature is something that you're not thinking about. Pleural area you're not thinking about. So what area are you thinking of localizing the problem to when you're talking about expectoration?
Tracheobronchial trees.
Airway, exactly, airway, because that contains mucus glands, that contains the gallbladder cells. So that's the reason that so that's what is it. Now you haven't committed yourself on the diagnosis, I know yet, but can you tell me in the context of COPD, what is the significance of colored sputum?
Colored sputum. White color sputum, and there is also mucopurulent sputum. Conversion from a mucoid to purulent, mucopurulent color, from whitish color to yellow color, suggests infection of the tracheobronchial tree.
Yeah,
infection.
Correct. And this has been backed up by very hard evidence. It's not really like just a loose statement. So that's one important thing. And why did you ask for postural or diurnal variation of cough in your first sentence?
Cough with expectoration along if there is a in empyema not empyema. In lung abscess, there will be increased amount of sputum production with change of posture, depending upon the lobe.
Okay, so bronchopleural fistula with empyema or lung abscess is what you're thinking about. That was one thing. So you've said that the patient has shortness of breath since 5 days initially, not associated with wheeze, not relieved with nebulizations. What is the significance of lack of relief with nebulizations?
It could be a patient could be a COPD patient who has been on home nebulization therapy, and with regular nebulization on home nebulization treatment, which is not relieved. It could be an which is maintenance therapy.
Rajesh, just a moment.
Is not able to relieve his symptoms.
Dr. Rajesh, just a minute. Your internet is not correct.
It's a rescue.
You're not audible properly. Just check your connection once.
No, by that time, helper is there, Shiva. He can answer.
Sir.
Yes, you answer where he stopped actually?
Regarding nebulizations at home.
Yeah, what is the significance that if it is reversible, if it is reversible with nebulization or irreversible with nebulization, does it imply anything? Does it mean any? Is there any difference? That's what he asked. Ashfaq, sir.
If there is any background history of COPD or bronchial asthma, patient can have a bronchodilatory effect after nebulization. So he may be relieved with the nebulization.
So bronchodilatory effect will be pronounced in COPD or asthma?
Prolonged in COPD.
So we are dealing with a case of acute exacerbation of COPD.
Yes.
So if there is incomplete or inadequate bronchodilation and there is no relief of symptoms, does that mean anything?
So it can be moderate to severe.
It will include severe. So what is the gold classification? Do you know? You have written about MMRC.
Yes,
is there any classification of gold in COPD?
Yes, sir.
What is that?
Based upon the spirometry values.
Yes. What is that? Mild, moderate?
Mild, moderate, severe, and very severe. Sir.
So acute exacerbation of COPD comes under which stage?
Severe to very severe.
Oh, severe. Stage 3. Sir, you please ask them. I think they have come together now.
No, so I just wanted to know, does the absence of a wheeze, does it rule out an airway problem in your, let's say in the ER or in the critical care unit?
No, sir.
You'll have to.
Absence of wheeze is
explain.
good or bad?
Absence of wheeze, not good, sir. It can be a sign of bronchoconstriction, bronchospasm.
In critical cases.
No, but like as sir is guiding you towards the answer, if you have a person who's clearly dyspneic, who's clearly struggling to breathe, and you auscultate him, and let us say who's hyperinflated, and you auscultate him and you don't find a wheeze. So what is your intuitive thought there?
It can be a silent chest also, sir.
Yes, absolutely, silent chest. So that's how you're going about it. So you have said that you have not mentioned any orthopnea is there or not, because that might be relevant to some of your differential diagnoses. So I just want to ask you, when you approach a history of a particular symptom, any particular symptom, let us say dyspnea, for example, how do you approach it? Do you have some construct in your mind about how to go about it? Because how to see that you don't leave out any questions?
Yes.
How do you approach a particular symptom?
So we'll elaborate the symptoms, characteristics of symptoms, and then we'll roll out one organ, like system-wise, we can roll out. Then we'll come to a conclusion.
Yeah. But what I'm trying to get to here is that when you take a particular history, you should be guiding us to the diagnosis, because by the time you finish, we should have some preconceived notions in our mind. So in that sense, whatever your eventual diagnosis is, your history should support the diagnosis, and you should document a lack of history. You have to say no history of your supportive differential diagnosis, which you want to eliminate. Is that right or wrong?
Yes.
Are you? So in that sense, how would you like to reframe the history of dyspnea in this case? History of what related to dyspnea and absence of what related to dyspnea.
So what is dyspnea? Definition simple. Subjective awareness of increased
Breathlessness.
work during
Breathing.
Yes. Then tell.
So here,
So subjective increase. So in now there's the subjective increase, less to more. That's what sir is asking.
Yes.
So, see, for example, let's say you've got an acutely breathless patient. You've got half a dozen diagnoses in mind, but you are favoring the diagnosis of, let us say, COPD acute exacerbation. All right. Now you give us some supportive history in dyspnea itself, which is favoring your supportive diagnosis, and you give us history documenting the absence of the supportive features of other differential diagnosis. Am I clear? Or
Here the patient
this
doesn't have
every single symptom. Yes.
Patient doesn't have any signs of orthopnea, history of orthopnea, or paroxysmal nocturnal dyspnea. PNDs.
Very good. Very good.
And
If he has that, then how is your diagnosis refuted?
so it could go in favor of cardiac issues or heart failure. So
Any lung cause also, which can cause orthopnea? Any lung cause which has a ball valve mechanism behind it?
no ideas.
So can you list out the causes of orthopnea apart from cardiac cause seen in the ICU?
So it can be due to moderate to severe pleural effusion, sir.
Okay. It's not classical, of course. You have more of a tripopnea there. It's not classical orthopnea. You have more of a problem while lying on the on a particular side. Generally, if you have a massive pleural effusion, the lung is compressed. The lung has the vasculature kind of disappears, and if you lie on the ipsilateral side, contrary to prevailing opinion, the greater shunting of blood occurs when the patient lies. So that's a kind of a tripopnea. That means to say twisted breathing or lying on one side. But what are the other causes of orthopnea related to the lung, as Professor Choudhuri has asked? Can you just, whenever you're in trouble, thinking about things, and all of us as clinicians are aware of this, just think in a systemic manner, not systematic manner, systemic manner. Think about the causes in the airway, in the vasculature, lung parenchyma, pleura, respiratory muscles, the rib cage. So sooner or later, you'll arrive at some kind of a meaningful differential diagnosis. So can you kind of proceed that way?
Based on pleura, it can be like, as you said, pleural effusion, the bilateral massive pleural effusion. And coming to airway, it can be like inflammatory, as in case of COPD.
Yes, COPD can cause orthopnea, but that's kind of rather exceptional rather than the rule. What about diaphragm? Can you think about diaphragmatic causes of orthopnea?
Can be possible, sir. Like the diaphragm pushes the lungs upward in supine position, which can cause breathlessness.
Diaphragmatic palsy.
Yeah, unilateral or bilateral?
Bilateral.
Yes, exactly. And not that the diaphragm pushes out the lungs, but because your gravitational advantage to your diaphragmatic movement is lost
because of
when you're lying down. So, and that's the reason you're getting orthopnic. Professor Choudhuri, you can.
I think they can proceed next.
Yeah.
Fever 5 days back is intermittent, not associated with chills, relieved with medications. No history of chest pain, palpitation, swelling of feet, decreased urine output, galley micturition, or abdominal discomfort. Past history. Patient is a known case of COPD since 5 years on regular treatment with nebulization formoterol 20 micrograms and budesonide 0.5 mg twice daily since 2 years and on home BiPAP therapy since 1 year. History of similar complaints in the past with a hospital admission 2 times a year for the last 2 years. Patient is also a known case of hypertension since 10 years on tablet amlodipine 5 mg twice daily.
See, you may be asked, some examiners, that how do you know that it is worsening? COPD is worsening, that there is acute exacerbation. I'm not asking you, but because you have a lot of slides, but they will expect 3 points. 1, worsening respiratory distress. Number 2, increased volume of sputum. Number 3, increased purulence of sputum. Fine. If they are asked that how do you clinically assess the worsening, then these 3 are the points that examiner will expect from you. Next.
So Dr. Rajesh and Dr. Shiva, I'm a little interested in this particular slide because here it says known case of COPD since 5 years on regular treatment with nebulization formoterol and budesonide. Now, generally, in the background of COPD, budesonide or the inhalational corticosteroid is used in certain very, very specific areas. Of course, that is called pulmonology. We were not going to get too much into that particular area. But that history makes me kind of wonder, what do we mean by COPD? So can you just explain what do you understand by the word or the term COPD?
Maybe it was like expiratory airflow limitations because of inflammation of airways.
Because of increased airway resistance first, then
emphysema test changes of the...
That will occur later. Sir is asking something even before that. Because formoterol is taking for 5 years. So if you relate, formoterol belongs to which group?
Long-acting beta-2 agonist.
Exactly. So what is it is used for?
Bronchodilation.
Bronchodilation. So when is bronchodilation achieved in COPD? That is what sir wants to know. Is the requirement increases over a period of time, or the requirement remains same, or it decreases in a patient of COPD? Requirement of bronchodilator?
It will increase. It is a progressive disease.
Always it will increase.
Generally, it will be persistent and progressive kind of.
And what is the role of budesonide in such cases? These are again becoming difficult, probably. But yes, Dr. Ashfaq, you please tell them.
Yeah, yeah, thank you, Dr. Anirban. But you see, the thing is, unfortunately, the gold guidelines keep changing year by year, but still we try our best to keep track of them. Now, the current use of steroid, inhalation corticosteroid in COPD is very selected because inhalation corticosteroid can also do a lot of damage. So now there is a new group this year, which is called as group E, or the E for exacerbator group. Certain COPD patients fall into the phenotype of exacerbator. What is predictable about these people? What is the history? They have exacerbations in the past. What is their future? They're going to have exacerbations in the future. So this phenotype is a very stable phenotype. And anti-inflammatory agents like inhaled corticosteroids are proven to prevent exacerbations. And every exacerbation is a milestone in the adverse progression of the disease, because once the exacerbation occurs, the patient's lung function will never go back to where it started. So the role of inhalation corticosteroid is extremely specific in the exacerbator group and in such of those COPD patients who have got some spillover eosinophilia in their blood. But what I would like to understand from you is how do you define COPD? How are you sure it is COPD? Based on, how would you be sure with the history up to this point of time?
Chronic cough associated with sputum production and shortness of breath.
Okay. So I'll just take 10 seconds more. How do you define a definition? What do you mean by a definition? See, you have to think about these things. The basic thing is a definition of a disease is a description that it alone fulfills. No other disease is capable of answering to that description. So in that sense, how will you differentiate COPD from its neighboring disease, which is asthma? Because asthma people also come into the ER with this kind of a exact same presentation. And the treatment implications are enormously different.
COPD is defined as a heterogeneous lung disease characterized by chronic respiratory symptoms like cough and sputum production with incomplete airway airflow limitation.
Very good. Right. So what is missing in your description of COPD? Where is the trigger now? Is it due? What have you missed in the history?
It can be due to lung infection or air pollution or any other trigger.
Yeah. So you need to document the trigger or rather the pervading thing like a smoking, because so far I think you've not come to the personal history, but I think it will be missing from the personal history the way I've reviewed these slides. So please go ahead. Because here, this up to this point, it makes me cast a little doubt on the background diagnosis, whether it is actually COPD due to a smoker or air pollution or whatever, or it is a kind of an asthma. But at the age, do you expect asthma to present at the age? See, she's 67. She had COPD since 5 years. So 67 minus 5 is 62. At the age of 62, the symptoms started. Does that happen in asthma at the age of 62?
Yes.
Generally not. Generally not. So asthma isn't out, and COPD is a little bit under a cloud in terms of the history at this point of time. So Dr. Anirban, you can say offer your comments.
Yes, sir. You have said everything. So we will go to the next slide.
Yeah.
So, sleep disturbed, appetite decreased, bowel habits are regular with a mixed diet. On arrival, patient is drowsy but arousable to commands. Tachypneic, speaking in a phrases.
Now, can a patient, yes, just 1 minute, can a patient also have sleep apnea?
Yeah, very good. Very relevant. Is your patient obese?
Possible,
Yes,
sir, but our patient has weighing only 60 kgs.
But height-wise, we don't know the height now.
160 centimeters.
Is it the weight only is responsible for sleep apnea or something else?
BMI is more appropriate.
BMI is one thing, but what about the fat distribution in the neck?
Yes.
No, can it be possible that your patient can have? Because what are the risk factors for sleep apnea? What are the common risk factors for sleep apnea and
Most common
COPD?
Most common is obesity.
Gotcha. Okay. But obesity is not a risk factor for COPD, is it?
Oh, sleep apnea.
I am asking common risk factors for sleep apnea and COPD. Smoking, I think, is common.
COPD, most common is cigarette smoking or tobacco smoking, sir.
Okay.
Exposure to
Air
biomass or air pollution, household pollution, and occupational exposure to heavy metal pollution.
What is the impact of OSA on obesity, on COPD, and on COPD on OSA? I mean, let's not go into the depth, but how is the interplay here? Is there a common phenotype based on these two occurring together? Yeah, there is. See, we call it the overlap syndrome. I mean, there are many overlap syndromes, as you must have read everywhere. But here, the overlap syndrome is all the more significant because it pushes the COPD patient into hypercapnia. So, in other words, into obesity hypoventilation. And the moment hypercapnia enters into the picture, the prognosis changes. The long-term prognosis changes. So, in that sense, as Professor Choudhuri said, it is imperative to rule out associated obstructive sleep apnea in a patient with COPD. And of course, these patients are very easily going to type 2 respiratory failure whenever they have a small infection or anything like that, especially when they have associated apnea. Yes, Shiva. Yes, Rajesh, you can go ahead.
Can you just look at general examination? No,
yeah, please. Unless Professor Choudhuri has some questions.
Yes, please go ahead. Yeah.
Spread rate of 35 per minute, and saturation, room saturation of 84%, and BP of 100/70. The patient weighs around 60 kg, height of 160 centimeter. Systemic examination, respiratory system, use of X-ray muscles of respiration are present, bilateral chest movements are reduced, and percussion, bilateral resonant note heard over all the areas. On auscultation, bilateral vesicular breath sounds are heard with a decrease in intensity. The bilateral polyphonic wheeze is heard. The cardiovascular examination, both S1 and S2 are heard. No murmurs are heard. Abdomen soft, non-tender, with no organomegaly. Sentinel system, patient is drowsy and arousable. No focal neurological deficit.
So here there's a slight, little bit of contradiction, I suppose, because do you think it's possible to make out bilateral vesicular breath sounds decreased in intensity and, on the other hand, wheeze at the same time? It's a little difficult, isn't it? If you would have a superadded wheeze, where is that wheeze? Bilateral wheeze and coarse basal crepitations. So if you have bilateral wheeze, I would imagine that you wouldn't be able to hear the vesicular breath sounds or decreased intensity of breath sounds, isn't it? No, we are only talking concepts here. I mean, there can be a typo here. There can be an error in.
These are basic things. The wheeze will, you listen to wheeze only. It will totally obscure the diminished vesicular breath sounds.
Exactly.
Secondly, is the patient is drowsy, but arousable.
Yes, sir.
So how does that affect his severity, or in other words, seriousness, or makes you see that whether that something is good or something is bad, or patient may.
Patient can be like in hypercapnic state or hypoxemic state because of breathlessness. So
drowsy can be occurring due to two things. One is
acute respiratory failure,
inadequate
ventilation,
oxygen reaching the brain. One. Number two, if there is in the blood supply, that also will produce a fall in oxygen, right? So if the two things, can the two things be present simultaneously?
Which ones, sir? Drowsy and
this drowsiness, the cause of both. One is the hypoxic cause and the hypoxemic cause. One, secondary to fall in the blood flow. Second, due to just a reduction in gaseous exchange, inadequate oxygen.
Sir, can be both. Maybe because of patient may present in hypertension, shock.
But this is not likely because in these patients, they tolerate a very high level of CO2.
Yeah.
So therefore, this is not a CO2-induced narcosis, right? So you will have to exclude other causes of hypoxemia also because they tend to tolerate very high levels of CO2, so they don't become drowsy because of hypercapnic A. The CNS doesn't. So if there is drowsiness, increasing drowsiness, arousable drowsiness, non-arousable drowsiness, then you will have to look for other factors for which can also cause drowsiness, right? Then you have said no focal neurology. Okay, take continue.
What is, just a curious point, what is the level at which cyanosis occurs? Because you've said cyanosis, no cyanosis, and the SpO2 is 84%. It's a very difficult subjective assessment of cyanosis. We are aware of that. But theoretically speaking, what is the level of, and what does it depend on? What picking up a sign of cyanosis, what are the factors it depends on? Saturations 84%. Do you expect cyanosis?
Less likely, sir. Saturations less than 70 or 75, or more or less than that can be possible.
No, there is a Gaussian curve. I mean, you have outliers at both the ends. But generally, most of the literature says below 85, you ought to expect cyanosis, except if in which circumstance? If the hemoglobin?
Yes, sir.
Yes. Why is that? Why don't you get cyanosis if the hemoglobin is less?
Oxygen carrying capacity will be decreased.
No, that's not the answer.
Which kind of hemoglobin is responsible for cyanosis? This is an MBBS question.
No, you have saturated hemoglobin, unsaturated hemoglobin. Now, what would you expect in a person with hypoxemia? What is giving the color of the blue, cyan?
Deoxyhemoglobin.
Sorry?
Deoxyhemoglobin.
Exactly. That's what sir is asking. So, in order to have reasonably sufficient levels of deoxyhemoglobin, you have to have enough of hemoglobin also. So if you have a hemoglobin, let us say at the lower end, like 5 or something like that, you're not likely to see cyanosis no matter how low the PaO2 drops. Isn't it? Okay. So I think you can go ahead.
Provisional diagnosis, acute exacerbation of COPD. My differentials are pneumonia, acute coronary syndrome, and pulmonary embolism.
Why acute coronary syndrome?
Sudden onset, shortness of breath. And
is there any chest pain? Did you mention anything?
Actually, there is no chest pain for these patients.
Age and hypertension.
Aspect of hypertension.
Okay.
So tell us what is against each of your competing differential diagnosis? 1, 2, 3, 4. Why did you not consider it as your primary differential diagnosis?
Pneumonia, because patient is not having a high-grade fever. Initially, the symptom will be fever, continuous fever, high-grade fever with pneumonia.
Do you expect fever in acute exacerbation of COPD?
Can be, sir. Pneumonia can exacerbate.
Can see medicine, anything can be there. But it's just like your kidney infections. If you have a cystitis, you don't tend to get the fever. But the moment your kidney parenchyma is affected, the fever response comes. Similarly, it's in the lungs. But yes, I concede that even in LRTIs, not affecting the parenchyma, you can get fever. But I think that just keep that in mind. And now you can move ahead with your arguments against pneumonia.
And the patient has background history of like multiple hospitalizations with exacerbations.
No. You have diagnosed inspection, palpation, percussion, auscultation. In auscultation also you have heard something which will you will hear something different in pneumonia. What is that? You said vesicular breath sound, no?
Yes, sir.
So do you get vesicular breath sound? In pneumonia, do you expect? You can get, but do you expect?
No.
What do you expect?
What do you expect?
Non-vesicular and maybe crackles.
Bronchial breath sounds. One. Anything else? Do you expect wheeze?
No, so less likely. Only crackles in the affected area of lung.
See, the thing is, you have different kinds of pneumonia, right? You know there is a lobar pneumonia, there is a bronchopneumonia. So bronchopneumonia, the primary mode is bronchial spread, and it kind of moves from the center to outside, centrifugally. Lobar pneumonia, it starts at the periphery of the lung and it involves the contiguous parenchyma. So you get a big patch of pneumonia, denser consolidation, and if you put your stent over it, the lung sounds are conducted better and it translates into bronchial breath sounds. You can have crackles at the beginning, but in bronchopneumonia, generally there's a much more diffuse involvement, even bilateral, and you are going to get wheeze and crackles, isn't it? So it depends. It's not, pneumonia is not exactly the same. It takes different phases. In a patient with COPD, is a normal chest X-ray, does it rule out pneumonia convincingly?
No, sir.
No.
Why?
What changes are already there in COPD lungs that this pneumonia changes are not picked up?
The hyperinflated lungs.
Yeah, partly that is the cause, but more specific.
So in a critical care unit, what are the conditions which will make you miss a pneumonia on a standard chest X-ray? It happens.
X-ray view, such as X-ray view.
Okay.
Technical, forget about that.
See, single X-ray is not progressive. Like can be any patch on the X-ray cannot be pneumonia. Sir, you have to see progressive.
No, my intention was you have a normal parenchyma without any patches in a patient with pneumonia. Is that possible? And in which circumstance is it possible?
Viral.
Sorry?
Viral.
Okay, maybe. What about severe dehydration? It's possible. So if to make an infiltrate, the lung requires water. To make the exudate, the lung requires water. So if the patient is severely dehydrated, it is very common to see, normal-looking X-ray. And pneumocystis pneumonia, that is notorious. You will have hypoxemia, and only when somebody has the sense to get a CT scan done, you'll pick up some kind of ground glass opacities. That also can present. So this is commonly seen in the critical care unit.
Please proceed.
Patient is initiated on the O2 support with 8 liters O2 with face mask. Nebulization given with salbutamol 2.5 mg and ipratropium bromide of 0.5 mg. Antibiotics injection sulfarazone sulbactam 1.5 gram AV after sputum collected for spooch for culture were given.
So, Dr. Shiva, if you had been in the ER at this time the patient was brought in, what device would you have chosen to give oxygen to the patient with COPD? Would you have chosen the same face mask, Hudson's mask, or would you have chosen something else?
Maybe non-invasive ventilation, some BiPAP support.
We'll come to that, I suppose. But initially, when the person comes in, you're just going to put him on oxygen, isn't it? So the question here is there another option other than a Hudson's mask or a simple face mask that you could use, and why? Why should you be thinking of other masks in a COPD patient?
Nasal prongs can be tried, sir.
Sorry?
Nasal prongs.
No, that is an option. But what are you concerned about when you're delivering oxygen to a patient with COPD?
Delivering high FiO2s.
How much? What is your concern? What is in your mind? What could go wrong? What could go wrong because of oxygen?
What happens if too much of oxygen or too less of oxygen can cause?
It will decrease the hypoxemic drive of the patient.
Yes. So you can cause hyperoxic hypercarbia. So what device would you choose? What mask would you choose to kind of prevent that? We are just talking about mask. We won't go into the fixed delivery systems or anything like that. Let's talk about the mask. Which mask would you choose if you had the choice? If it were available?
Eventually.
Exactly. Because of
Fixed delivery.
the fact that
FiO2 can be controlled.
Yeah. So what is the FiO2 that you would like to give to a patient with COPD?
On the higher side or lower side? Or average?
Target saturations around 88 to 90.
Exactly. Okay. That's great. That's great. That's what I was probably thinking of next. That's wonderful. Okay. Okay. So how much does FiO2 does 8 liters per minute with a face mask translate into?
It depends on the patient respiratory efforts that the patient demands, sir.
Agreed. It's a variable flow system, so we have no control on the exact FiO2. But what is the thumb rule? How much FiO2 is the patient likely to be getting?
Around 0.5.
Sorry?
Around 0.5 FiO2.
What is the calculation?
8 liters multiplied by 4 in addition to 21% on movements.
Okay. Okay. I think I didn't hear of that, but I think that is almost similar. Okay. So he's getting something close to 50 or 60% oxygen, 0.5 or 0.6, which is not so great for a COPD person. And while we are at it, can I ask a slightly deeper question? What is the theoretical danger of starting nebulizations in a person with borderline hypoxemia? So the danger of oxygen we know, but we don't worry about the danger of nebulization because the person is already in oxygen. What can happen if the person has a borderline hypoxemia and you're giving nebulizations?
They're prone for arrhythmias. Hypoxia plus this beta-2 agonist can cause arrhythmias.
So lots of side effects, but what I'm pertaining to is just like your nebulization is a bronchodilator, it can also vasodilate some of the lung vessels and to areas where there has been a hypoxemic reflex shutdown. So sometimes when you initially start the nebulization, there will be a drop in the oxygen and then the oxygen will start to rise as the generalized bronchodilation occurs. So if you're having a mask put on, it's fine. But if the patient has borderline hypoxemia, then it can be a little bit of an issue. When will you do the ABG after starting oxygen? 10 minutes, half an hour, 1 hour?
Initially, we'll do ABG, sir. Before
Initially, if you do, you won't get anything. You stand. What does book say? They give a range 1 to 2 hours. Why? Do you expect immediately to, what duration of action, their onset of action, how much it is the onset of action?
Of bronchodilators.
Yes, you are giving the salbutamol, ipratropium bromide, and budesonide, all three.
It will take around 30 minutes. So after
It will take 1 hour. So 1 to 2 hours is the standard book.
So, Rajesh, why did you choose cefoperazone, sulbactam? And what should you be thinking of when you're trying to start an antibiotic for a COPD patient? I mean, is it like augment co-amoxiclav or cefoperazone? Would you like to go for more a gram-positive cover or a more gram-negative cover or a kind of a broad-spectrum cover? How would you plan it? Or is it just reflex? Is there some thought process behind starting an antibiotic, choosing an antibiotic in COPD exacerbations?
Patients with frequent exacerbations and a history of structural lung disease are more prone to have a Pseudomonas.
Structural airway disease, I can accept, but recurrent exacerbations are not yet correlated with,
history of hospitalization and use of recent use of broad spectrum antibiotics.
Recent use, fine. But recurrent exacerbations and recent is not, kind of yet accepted. But what is accepted is if you have a poor lung function, there is likely to be colonization with the more dangerous gram negatives like Pseudomonas. What is the commonest organism that you need to cover in COPD exacerbations, irrespective of the class of the severity?
Most commonly Streptococcus.
Sorry?
Streptococcus pneumoniae, sir.
No, that we are talking about pneumonia there. We are talking about community-acquired pneumonia there.
Patient with these previous history of hospitalizations and
you lump all the COPD patients together, which is the commonest organism across the board, regardless of the severity. And that will determine your antibiotic choice. That's important.
Gram positive or gram negative? First, tell that.
PTCL we consider gram negative.
So
Klebsiella.
Hemophilus influenzae is now currently the commonest, because that is most recent literature. But like you said, you still can't rule out other organisms, so you have to broaden your antibiotic slightly. But what you're covering basically is hemophilus. If the patient has got very severe lung disease, sure, you can go to an anti-pseudomonal cover like you've done with cefoperazone, sulbactam. Sputum testing is required for this or no?
You have collected for culture, no?
Yes.
How much sensitivity and specific it is sputum sample in detecting your organism, or
30 to 40%. Cultures only become positive, sir.
We're talking about community-acquired pneumonia, or talking about acute exacerbation COPD. What are the recommendations for in which patients will you test sputum in community-acquired pneumonia? And then which patients will you test in LRTI, in acute exacerbation COPD? There are very clear recommendations about community-acquired pneumonia, not so clear about acute exacerbations of COPD. So what are the recommendations in which you test, whom to test, whom not to test?
The patients who will suspect, like in case of acute exacerbation, if you suspect infective etiology of exacerbation, generally we send sputum cultures.
Conventional literature says, like early on, we used to believe that 50% were exacerbations were infective, 50% were not. But now, by and large, most exacerbations are to be treated as infective. So we know, but we have to be selective about sputum testing, because most of these sputum will be sampling the upper airways. It may not give relevant information. But in community-acquired pneumonia, if the person is admitted specifically in the ICU, it is worthwhile and meaningful to check the sputum. In LRTI, or exacerbations of COPD, the information is not that valid because you may not get that kind of information, the specific and sensitive information. Okay.
Absolutely. You can go ahead.
So ABG in here shows acute respiratory acidosis, severe acute respiratory acidosis.
It is 7.19. So that was the ABG before you started on mask or after started on mask?
Before, sir, just on arrival on room.
So is that an indication for to start something else if your pH is 7.19?
Yes, sir. Rather than starting on oxygen supplementation with face mask,
Yeah, to start for
with non-invasive ventilations.
Non-invasive ventilation. But you said that your patient was drowsy. Is drowsiness somewhat a relative contraindication for NIV?
It's a relative contraindication, but patient is arousable and
arousal. So patient is arousal. So although drowsy, patient is arousable. So little bit of margin is there. What is the PCO2? 83. Okay. Shall go ahead.
Dr. Rajesh, I'll just ask you one very silly question, but it has very great importance in terms of concepts. So you have a PO2 showing 110 millimeters of mercury. And we are now concerned that it is hyperoxic hypercarbia because we have given him a lot of FiO2 with the simple mask, isn't it? So is it better to lower the FiO2 that the patient is getting or to stop the oxygen altogether? Because no oxygen, no respiratory suppression, which is okay for you? So I know what you're going to choose, but you have to explain to me why.
I want to lower the O2, sir, not completely off. I
Why?
want to titrate SpO2, sir. Saturation,
okay. 88. Now, why not stop it? You are going to say the patient may run a risk of hypoxemia. But I just want you to understand one small concept. You have understood, you know what is known as the alveolar gas equation?
Yes.
Because, you know, as critical care physicians, we have to. So if you look at the P capital AO2, which means the alveolar oxygen, then that is dependent on the parametric pressure of whatever sea level or wherever you are, minus the water vapor pressure, minus the ratio of your carbon dioxide by your respiratory quotient. Now, respiratory quotient, let's not get into that. That's a difficult subject. But here you've got 8 liters per minute. You've got an approximately 0.6 FiO2. Your P capital AO2 is equals to 760 minus 47, which is the water vapor pressure, into, let us say, 0.6 minus take away your carbon dioxide of 83 by 0.8. Your answer comes to 323 alveolar PaO2 of 323 millimeters of mercury. If you substitute that 0.6 by room air 0.21, the answer comes to not 323, but to 38 millimeters of mercury. 38. The guy dies straight away. And why is that happening? Because your carbon dioxide level in the alveoli is not allowing your oxygen to build up there. So if you look at the alveolar gas equation, the calculation says 38 millimeters of mercury in the alveoli, much less in the blood, much less in the brain. You will have anoxic brain damage there and then. So the rationale for stimulating the respiratory drive is to not cut off the oxygen completely. Give him some amount, and the conventionally accepted amount is 0.28. Isn't it?
Yes.
Please proceed. Sorry for that.
ECG shows normal sinus rhythm. The patient is initiated on NIV support for type 2 respiratory failure. So BiPAP with an IPAP of 14 centimeter of H2O and EPAP of 16 centimeter of H2O, in STT mode with AVAPs on, and patient was shifted to ICU.
So what should you target in ABG if you have to follow? Should it be PO2? Should it be PCO2? Should it be pH? What should you target?
To target normalization of pH. And
pH and PSC.
ECO2 should be according to patient baselines. If you have a previous ECG, it should be target.
Okay. So let's see what is BiPAP. What is the full form of BiPAP?
Bilevel positive pressures.
So with the BiPAP, IPAP of 14 and EPAP of 6, what is its in the pressure support is how much?
Pressure support of 8.
14 minus 6.
Okay. Chalo, next.
After ABG,
sorry, just one small point on based on this thing. When would you not go for NIV? Or ventilate him straight away, intubate, ventilate straight away. In this kind of presentation.
Life-threatening acute respiratory failure. There is excellence.
Give me the next indication. Give me the concrete, hard evidence-based indication numbers. When would you straight away go for intubation? Call out for the intubation.
Like I'm saying, one unconscious. That is, you won't go for it.
Respiratory arrest.
No, that's fine, but that's the it's intuitive to think about that. But what I'm saying
is pneumothorax, what will you do if you suspect pneumothorax?
Pneumothorax. First, it's a medical emergency. We have to.
Will you give an IV?
No, sir. No, sir.
Any other conditions? So, like that, I am asking.
Like the patient is in coma, sir.
That I told, unconsciousness, coma, same thing. Then
with the copious secretion, sir, and high risk of aspiration.
Upper GI bleeding, aspiration.
Upper GI bleeding, or hemodynamic instability.
So let us tell me the pH at which you consider NIV and which you consider direct mechanical invasive mechanical ventilation.
Consider NIV at a pH of less than 7.35, sir. Up to 7.242.
Up to 7.25, say roughly. 7.25 to 3. You consider NIV. Below 7.2?
We'll go for mechanical ventilation.
Why? Because studies have found that it is only beneficial in moderate degree of A. In severe acidosis, it is not possible. What is dynamic hyperinflation?
Due to expiratory flow limitation, there is incomplete time for complete expirations. So, with each and progressive breath, the amount of air will be stacked for every breath. There will be air stacking with every progressive breath.
So how will you detect? How will you detect? So this patient, suppose patient's pH is less than 7.2. You decide to intubate. So after you intubate, how do you, on which mode you will choose?
Either mode can be used.
Any mode can be fine. How will you detect dynamic hyperinflation?
It can be ventilator graphics of waveform.
Graphics. So what thing you see in graphics?
The expiratory waveform doesn't touch the flow form, does not touch the baseline side.
Yeah. So you determine the auto PEEP. How do you detect auto PEEP?
Volume.
Pressing the
Kola volume curve and the volume time.
No, putting inspiratory hold or expiratory hold? Expiratory hold. So what is in these patients, there are two kinds of PEEP, dynamic PEEP and static. So which will vary in these patients? Suppose in these patients, some intensivist who is not so expert like you tries to bring down the PCO2 from 90 to 40 and tries to ventilate using a large tidal volume, puts up the rate. So what is the most common problem that he will create?
Private auto beeps.
So what will happen?
Hemodynamic compromise, it can cause intrathoracic pressures will be raised.
Absolutely. So that auto beep, that which he has created by trying to, that is a dynamic or static? Dynamic. So the static beep that you have seen by pressing the on the expiratory hold, if you detect it is too high, then what will you give? How will you try to compensate?
Decrease the respiratory rate.
Decrease the tidal volume. Increase
those things are fine. Those things are fine. You increase the flow 680 to 100 mLs, make the expiration prolonged. But if the static PEEP that it is high, then what? Then you will have to give extrinsic PEEP. Remember, this is opposite, but this is a fact which is everybody knows but cannot answer during exam. When the static PEEP it is too high, then you will have to compensate by giving it.
It's like somebody told me, I don't, but I remembered it lifelong. If you can't climb directly on the table, climb on a chair first and then climb on the table. So that's the exact analogy what Professor Choudhuri was talking about. So just one quick question. You have done what Professor Choudhuri has said. You have overventilated the patient. You have kind of washed out the carbon dioxide very, very rapidly. Now somebody does an ABG. What is the diagnosis on the ABG? What, like you got respiratory acidosis, respiratory alkalosis, metabolic alkalosis. Which of these would you see on the ABG that is done after washing out the carbon dioxide too quickly? Four options: respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis.
Respiratory alkalosis.
You can work out if you think.
Respiratory.
See, the patient has got COPD. The patient has been retaining carbon dioxide. Carbon dioxide gone up. What has happened to the bicarbonate?
Increased.
It increases. What happens to the pH? From previously, the pH, after the compensation, the pH?
Increase.
Comes towards normal. All right. Now you've got a pH which is coming towards normal. You've got a bicarbonate. You've got a bicarbonate which is high. You've got a carbon dioxide which is still high. Now suddenly you bring down the carbon dioxide. Your bicarbonate is still high. Suddenly bring down the carbon dioxide. What happens to the pH? Alkalosis. Very good. Alkalosis.
Metabolic
pH, alkalosis. Your bicarbonate is high. What is it? pH and high bicarbonate is?
Metabolic alkalosis.
Metabolic alkalosis. So this is actually a kind of a fallacy that we see. Metabolic alkalosis. That's why it's been given a name which is called post-hypercapnic metabolic alkalosis. So this is exactly what, this clinical circumstances. Okay.
APG after 1 hour the admission to the ICU showed after BiPAP therapy the pH is 7.0 shows a worsening of respiratory acidosis with a pH of 0.7 and PCO2 of 117.2. Hence, the patient is treated as an NIV failure, and the patient is intubated and connected to a mechanical ventilator. With initial setting of a volume control mode, a tidal volume of 380 ml, a respiratory rate of 14, and PEEP of 5, and FiO2 of 40, with the IE ratio of 1:3. IV antibiotics, nebulization is salbutamol and ipratropium bromide every 4th hour are continued, and other supportive medical care with like IV fluid management, everything was continued. Labs on the day 1 for HB of 11.11 and TLC of total leukocyte count of 9,400, differential count, neutrophil 77%, leukocyte 14%, eosinophil of 1.5%, monocyte 6.5%, base of 0.7. Platelet count and within normal limits, Serum electrolytes, RFT and LFT were within normal limits. Complete urinary examination were within normal limits. ECG shows sinus rhythm. 2D echo was done, which showed mildly dilated RA-RV with dilated PA, pulmonary artery, and a mild TR, moderate PH, and RVSP of 55 mmHg. And mild concentric LVH, no RWMA of LV, good LV and RV systolic function with ejection fraction of 60%, great diastolic dysfunction. This is the X-ray.
One important thing, just sorry to interrupt you there, which is also asked during exam. Means at least it has been asked when I was examiner along with my others. What are the possible asynchronies you notice during ventilating these patients? Do you see asynchronies?
Yes.
Is there any way to determine asynchrony? There can be several types of asynchrony: flow, trigger. So what kind of asynchronies are common here? It is ineffective triggering. And how do you calculate the asynchrony? Number of asynchronies per minute divided by respiratory rate into 100. Right? So that gives you a percentage. And when do you consider it as a severe? When this percentage is more than 10%. It is considered as severe. And then you come on to the various methods of how you can reduce the asynchronies. This is the important question often asked. You continue now.
The chest X-ray shows an AP view, which shows endotracheal tube in situ and lung parenchyma is also normal. So,
Dr. Rajesh, does this X-ray suggest to you? This is a AP, no? It's AP. Obviously, yeah, because he's on endotracheal tube and all. So, does it suggest COPD to you? And why yes and why no?
Seems hyperinflation of lungs.
How would you say that? How would you say, assuming, let us say you got a, you could just by some magic, you convert it into a PA view where you can make some clear measurements. So how would you say that this person is hyperinflated?
Lung parenchyma generally do not cross 7th ribs, 7th costal margin, 7th rib costal margin. If it is more than that, you can say.
Yeah, but what is the most sensitive sign? I know we are scraping too deep here, but what is the most sensitive sign of hyperinflation on a chest X-ray?
Flattening of a diaphragm.
Very good, excellent. So how do you know this flattening of diaphragm? How would you measure? How would you objectively measure a flattening of the diaphragm?
Appearance of more than 7 ribs in the AP.
See, the problem now is that we are now accustomed to digital X-rays, which have no size uniformity like we used to have the previous, large X-rays. So in the large X-ray, if you draw a line from the costophrenic angle to the cardiophrenic angle, then you draw a perpendicular on top of that to the peak of the diaphragm, then that should be less than 1.5 centimeters. So that has been actually the gold standard for assessing the hyperinflation. Today, we are in the soup because A, we don't have those kind of standardized sized films. Secondly, in the AP film, it makes it notoriously difficult to kind of make these kind of assessments. So I agree with you, maybe hyperlucency of the parenchyma and the other indirect signs you can go by saying, but still in a COPD patient, even though he may be having some right heart failure, this kind of shape of the heart is a little bit unusual. And maybe have you confirmed the findings of this chest X-ray by doing a CT scan later, just for our reference?
In the current admission, no, sorry.
All right. No, it's okay. It's just a question. So now this guy had fever. This lady had fever. She has got maybe a little bit of a haziness in the left lower base, especially, and I can see the silhouetting of the lateral part of the left hemidiaphragm, because you can see the medial part, you can trace it out well, but it's losing its configuration a little bit. So, and I don't know, maybe there could have been a little bit of a mnemonic infiltrate in this kind of a COPD as well. Very difficult to say unless you have a CT scan, but I think this is just a comment. It may be, it's to be taken with a pinch of salt. Yes, please go ahead.
After ventilating the patient these are the ABGs, the progressive mechanical ventilation was controlled throughout the next 24 hours, and the ABGs transferred towards improvement in the pH and washing out of CO2. On day 2, patient had stable hemodynamics, a temperature of 100.4, and labs turned out to be HB of 10.6 and total leukocyte of 12,740, and with a neutrophilic predominance. Serum electrolytes were within normal limits. Patient is ventilated with volume control mode with a tidal volume of 380 ml, rate of IE ratio of 1:3 and FiO2 30% with target SpO2 of 92. The serial ABG transfer towards improvement with normalization of pH.
I can't see this slide. Can you read out the values? If
these are all improving, it seems. They are trying to prove that it's all improving. But so if I ask you, what is the single most important thing that if you have learned from this case, what it will be? Assuming that all these things which you have narrated has actually happened. That your NIV, the choice of your NIV should have been avoided. Means you should have started the patient on invasive ventilation at the very beginning when the patient pH was less than 7.1 and all those things. And so the patient further worsened, and then you put the patient on invasive ventilation, immediately he improved. Now, next important thing is weaning. Have you discussed weaning? Are you coming into it or?
Yes, sir.
Okay.
And if the patient was maintaining stable hemodynamics, no fever spikes were there, and TLC counts were improving. Total leukocytes were improving. Serum electrolytes were within the normal limits, and the sputum cultures showed no growth. After a successful spontaneous breathing trial, patient is extubated to NIV.
Another important question which was asked in the last exam. Hacker, you know?
Hacker score, yes.
What is it? Hacker score?
To predict
H
the
for
NIV failure.
NIV failure. What does H full form I'm asking?
H for heart rate, sir.
Yes.
A for acidosis.
Correct.
C for consciousness, sir. GCS level.
Correct.
O for oxygenation, sir. PF ratios. And R for respiratory tachypnea.
Okay. So you should know that hacker and respiratory failure. Now, what should be your weaning strategy in patients with acute exacerbation of COPD? Can they fail weaning? Number one.
Yes. Yes.
Yeah. So if they fail, what will be the common cause of their failure?
Like before primary pathology, before resolution of primary pathology.
Yes, primary pathology. But primary pathology in COPD is not possible to resolve.
Yes.
So something else is possible to resolve. What are the things you will see? Secretions should come down sufficiently. Number one. Number two.
Clearance of secretions, if in cases low rate.
Secretions, I have told you. You tell me something else.
Consciousness level, sir.
Consciousness is one. Number two, what initially when we were discussing, we told they have a very high demand. The drive is high. So you have to increase the flow is very high initially, right? So here when their demand has reduced, when you are able to reduce the flows, that is two. Number three, Patient does not experience any the acid. This is the pH is stable over a period of time. So these three conditions one has to take before you. So what is the rest of the things, you know, the weaning index and everything.
In the good old days, when, you know, we were very young with critical care practice, there used to be a concept that let this patient earn weaning. Yani let him continue breathing in this very intensive manner, and eventually we will just intubate him just before he crashes. No, we know absolutely, we know that's absolutely wrong. But I just want to ask you one question based on what Professor Choudhuri said, that if you continue to let the patient struggle for a long time and you delay appropriate respiratory support in either terms of NIV or in ventilation, what is likely to be the outcome on weaning and why?
Patient may get into prolonged weaning, sir, because pneumonia, ventilator-associated pneumonia is a risk factor on prolonged ventilation if you don't have a protocolized based weaning plan.
No, my question
Suppose
was,
patient does not develop pneumonia.
Yeah, the patient, you've allowed the patient to breathe, increase work of breathing for far too long before giving him appropriate respiratory support, either in terms of NIV or in terms of invasive mechanical ventilation. Now, how does that impact the delayed weaning? What is the bridge? What happens that delays the weaning in such a patient? No, let's not talk about, I mean, irrespective of pneumonia and hypokalemia and, you know, cardiac issues and all that. What could delay the weaning in such a patient? Per se, too long a trial of observation. Something to do with the diaphragm?
So it can be a diaphragmatic palsy. Like if you
not palsy, it's a weakness.
Weakness, sorry, weakness. If you prolong
weakness can be a very generalized term. What specifically can go wrong with the diaphragm if you have made the patient breathe too hard?
Disuse atrophy.
No, there's no question of disuse. You've not put the patient yet on ventilator. You've not paralyzed him for a long period of time. You've not done that. You just made him work too hard. What can go wrong in the weaning? Why would it take a long time in such a patient? See, there is something called inflammatory damage of the diaphragm. The more the diaphragm works inappropriately, there will be physical infiltration with inflammatory cells. And once those accumulate to a large extent, it's going to take a long time for them to clear off. So whatever you call it, do you call it myositis or do you call it diaphragmatic inflammation? But this is actually a reality in clinical practice. And it actually was a reality in the clinical practice of, you know, the good old days, bad old days, whatever.
And still one should be very careful. Diaphragmatic injury. This is a form of iatrogenic injury.
Exactly. I think we are done. Is it the last slide?
Yes.
We've come to the vaccination. So since this patient was from Hyderabad, I want to ask Dr. Shiva and Dr. Rajesh this is actually has a lot to do with what Dr. Choudhuri just discussed. The patients, when they're describing their breathlessness, they sometimes come and say, Dr. Saab, upar ki saans upar, niche ki saans niche. Have you heard this phrase in your practice? Let's say you're asked to see a patient in the ER before the patient goes to the ICU or in the ICU itself. Upar ki saans upar, niche ki saans niche. It's a curious term. I think it's only peculiar to Hyderabad. I used to be very kind of amused by this until I realized that when the patient has got bronchospasm and develops dynamic hyperinflation or whatever, air trapping, then expiration becomes a problem. When the bronchospasm is there, expiration becomes a problem. When expiration is a problem, then dynamic air trapping starts and the patient becomes hyperinflated. Once he's hyperinflated, inspiration becomes a problem. So neither the patient can breathe out nor breathe in. Upar ki saans upar, niche ki saans niche. So I thought this was one of the better descriptions of air trapping than I've ever read anywhere. And I used to have a huge amusing time when I used to listen to this. So you have to listen carefully. That's what I learned. So Professor Choudhuri, any last final questions for our two?
I think we have nicely covered and they have presented and they have come to know most of the questions that we will be asked, but I will still advise them to go through, read again, static PEEP, dynamic PEEP, how the effect of PCO2 on the brain and its effect simultaneously on the respiratory drive, and how that respiratory drive can be altered during mechanical ventilation, because these are the areas where even if you know, but if your concept is not cleared, you tend to get confused at the time of exam. When the examiner asks these questions, and sometimes he may ask even very simple question, the effect of CO2 on brain, and simultaneously what will it will be on the respiratory drive, and how will you check the flow, and what will you do even in spite of a high flow, the patient's oxygen is. So these are simple, workable, but your concept on these things should be very clear. That how much external PEEP you should give if the patient is developing too much of auto PEEP despite invasive ventilation. So for how, when should you check, how often, if you see. So these changes in ABG, the changes in X-ray, and now of course we haven't touched upon, but ultrasound. This is also an important area from where you can expect some questions. So otherwise this will be very easy, and I think today's discussion will definitely help you. Dr. Ashfaq sir has given you a lot of ideas, so your basic concepts must have improved after hearing him, and I think that you will be comfortable with this case in your exam.
So thank you and well done both. It's not easy to sit before a lot of virtual audience and be grilled. So good, well done, and keep it up. And everything is a learning curve. In medicine, life is a learning curve, and once it becomes a flat. It only becomes a flat line when our ECG becomes a flat line. That's what I believe. So thank you very much, and thank you.
If there is any question from any, because we were not hearing from, there are a lot of chat. 14 I have not seen. Dr. Shashidhar, may please.
Yeah, among 14, only one question is there. So rest are all answers to the questions which you have asked. The last one question is PEEP of 5 is justified in this case? With the PEEP of 5, when they started the ventilation, they mentioned that the starting PEEP was 5. So
yes, Shiva and Rajesh, you tell. Now you know. Is 5 of PEEP justified? If it is less, more, adequate, how will you know that?
Initial setting can be from PEEP.
You can only know that if you know what is the patient's intrinsic PEEP, then only you can say what. Initially you have started with 5 PEEP, and after that, whenever you have checked by pressing the expiratory A, then you have. So that reminds me of another important question that sometimes students fail to answer during exam, is that how will you, if this patient during weaning is taken on pressure support ventilation, how will you change your expiratory? Because the expiratory trigger sensitivity is by default set at 25% in most of the ventilators. So whether you increase it or decrease it. So that is simple, that if in these patients, you want a prolonged expiration. So in this pressure support ventilation, the machine cycles from inspiration to expiration when 25% of the peak expiratory flow is achieved. So since you want the expiration to be prolonged, you want to set it at 30 or maybe 33 or quickly. So therefore, you set this expiratory trigger sensitivity slightly higher than normal. Just the opposite of ARDS. In ARDS, you want a greater inspiratory time. So you bring down that ETS to 20 or 15 like that. But in COPD, exacerbation during weaning with pressure support, you increase it to 30, 33 watts. So this is I forgot it. So I'm telling you.
Yeah, it's one of the commonest forms of asynchrony in COPD patients. This kind of what Dr. Professor Choudhuri has mentioned on pressure support ventilation.
So the next question is role of IV magnesium sulfate in case of COPD exacerbation.
I think Dr. Hasan will tell it better.
Unlike asthma, there is no evidence to say that IV magnesium sulfate benefits COPD. And even in asthma, it doesn't have a colossal effect. But in COPD, there is no evidence to say at all that it is beneficial.
Yes. So next question is, if intubated and paralyzed, should we still give PEEP or zero PEEP to further reduce the IPEEP?
See, when paralyzed, there is no question at all, because in paralyzed, it is paralyzed. Patient is not fighting. So there is immediately. It is only when patient is allowed to breathe. But first of all, the question that why will you paralyze in the first case? Unless there are compelling circumstances, we don't paralyze. If we paralyze, then we do not, it is not possible. So that time you know that whether you are actually over-treating or you don't know it. So that is not possible. Only when adequately sedated patient who is not fighting, in that you use and you can give external. Yes, sir. So,
no, I mean, that's exactly. But ZEEP has very limited applications nowadays, because even when you and I are breathing, in a normal physiological way, we are kind of maintaining a little bit of an auto PEEP. So that's called physiological PEEP. And especially if you look at an emphysema patient who's breathing with pursed lip breathing, the typical pursed lip breathing of emphysema patients who breathe like that chronically year after year, day after day, that person is increasing the auto PEEP to prevent the dynamic collapse of his airways. So in that way, some amount of PEEP is normal for everybody.
Absolutely. Achha, Venkat has asked 2 questions about vaccination and steroids, I guess.
Yes.
What are the questions? I can't see them.
It is
vaccination and steroids.
Role of vaccination and role of steroids we have discussed in a lot. So I think vaccination part, Dr.
Yeah. So steroids, see, the thing is, I just want to make one quick point here. There is a difference in asthmatic inflammation and COPD inflammation. So when you're talking about a stable COPD patient and a stable asthmatic patient, almost every single patient with stable asthma would merit inhalational corticosteroid. Not so with COPD, where, like we discussed, some selected patients would merit inhalation corticosteroid. But in acute exacerbations, systemic steroids are the standard of care, whether the patient has got an acute exacerbation of asthma or acute exacerbation of COPD. They are the standard of care. So we have to give the steroid. Now, coming to vaccination, it's become extremely important in COPD patients to give pneumococcal vaccine. Influenza is a universal vaccination for all of us. Regardless of whether we have COPD or no COPD, every adult or even children should be vaccinated against influenza with a quadrivalent vaccine. Pneumococcal vaccine is known to prevent the recurrent exacerbations as well as prevent the cardiovascular mortality of COPD patients in the long term. So there is excellent, reviews by Danish original studies by Danish investigators, which have come into the gold guidelines, etc. So Pedersen et al. And all these people, there is absolutely hard evidence that pneumococcal vaccination is to be given to COPD patients. Now you have 2 vaccines. One, you have the conjugate vaccine and you have the polysaccharide vaccine. Polysaccharide vaccine advantage, many strains. Conjugate vaccine, fewer strains, but because it's a conjugate, it's a much more potent and more effective vaccine. So what do? Normally in a COPD patient, we don't discriminate that much. We generally give the polysaccharide vaccine. But if a patient is immunosuppressed due to any reason, then it makes sense to offer him both the vaccines separated by approximately 1 year. If the patient is significantly immunosuppressed, you don't wait 1 year. You give the conjugate vaccine first, wait for only 2 months, give the polysaccharide vaccine. So when you're sequentially vaccinating, give one vaccine, wait for 1 year, give the other vaccine. Which you give first is not important. But if you're waiting for only 2 months, it is important to give the conjugate vaccine first, then you give the polysaccharide vaccine after a gap of 2 months. I hope that's clear.
Yes. So
Absolutely.
Yeah, one more question, sir. If there are no previous ABGs available, means baseline PCO2 is not known, then what should we target while reducing the PCO2?
Yeah, so that's a little difficult question here, but you see, normally what you do is when you look at an ABG, you try to work out the compensation, you try to work out whether there are any associated acid-base disturbances there. So if you have a person with respiratory acidosis, you take the carbon dioxide, you subtract 40, which you assume is the normal baseline carbon dioxide, and then you multiply it with a factor of either 0.2 or 0.4, depending upon whether you think the acidosis, the process is acute or chronic. Acute, you multiply by 0.2, chronic, you multiply by 0.4. How do you know which one to do? If your respiratory symptoms are more than 3 days, you use the chronic equation. If it's less than 3 days, you use this thing. So once you use that, you can retrospectively calculate the carbon dioxide that the patient had to begin with. But it's not a foolproof way. It's just kind of a rule of the thumb. So in other words, I can't answer that question.
Yeah, if you don't have PCO2, don't worry. You don't target PCO2 at all. Exactly. You target the pH first. Once the pH becomes normal, automatically everything will become normal.
Last question, sir. Cause of weaning failure in these patients, can it be steroid-induced myopathy?
Rare. See, thing is, in a COPD exacerbation, how long should you be giving the steroids for? What is the evidence? The evidence is that even if you give for 10 days, the outcomes are not as good, long-term outcomes are not as good as if you give for 5 days. So approximately 5 days, exceptionally a little bit longer, is the duration of the steroid course. Now, if you are exceeding that course, then you are exceeding it for a different reason. And if that is the case, then of course you have the possibility of steroid myopathy. But in a standard garden variety of COPD, where you're giving 5 days of the systemic corticosteroids, we wouldn't anticipate any such problem.
And the dose of steroid also, what we give is 1 to 2 mg per kg, not more than that. So
yeah, but again, with parallels with asthma, it is now known that it's not necessary to go on an extremely high end of the steroid dose in airway diseases. Maybe you talk about collagen vascular diseases and vasculitis and all those things, that's a different matter. But in airway disorders, it's not necessary to go with extreme high dose. But what theoretically could be done is, the first dose could be hydrocortisone, because hydrocortisone gets quickest achieves the level the quickest. Then you could go with the methylprednisolone, because it has the highest levels of all these steroids in the epithelial lining fluids. But these are theoretical constraints. What we normally do is we go straight away with methylprednisolone, and we stick to methylprednisolone till the end of the steroid course. Professor Choudhuri might have some insights.
So it is true that steroids may cause myopathies and may cause delayed or failure in weaning. We are concerned about it, but at what dose for how long? There is no such one-size-fits-all strategy, cannot be predicted. And different patients have different level of tolerance. And we have to continually examine the patients and try to withdraw as soon as we think that it is no longer required.
Perfect.
So thank you, sir. All the questions are answered. I think this is an extremely good webinar to watch because two senior most faculty giving more answers than questions in the session. So it's extremely useful for the students all over the India. So by tomorrow, I think more than 2,000, 3,000 students will watch this video, sir. So thank you for giving your time and inputs.
Thank you. Sasi.
It was a pleasure and to hear from Dr. Ashfaq.
My honor, Dr. Anirban, to share the podium with you. Thank you very much.
Sasi, I just wanted to thank, can you hear me, sir?
Yes, Venkat.
Yeah, sir. I just wanted to thank you for your time and valuable inputs. It's a learning experience for many of us, not just for students. Many consultants are logging and gluing to all those wisdom which you are sharing. And also thanks to Anirban, sir, from Delhi. He is sparing the time. He has been an academician and been a part of many postgraduate academics. Thank you, Anirban, sir.
Thank you. My pleasure, Venkat.
So there were hundreds of students gluing more than 2 hours. And probably there will be, as Sasi said, a few thousands in a day or two. The students will keep on learning from all these sessions. Thank you all. Sasi,
your
please
report
go
is great. You are doing a great job, Venkat. Keep it up.
Okay. So this is all because all our teachers, faculty, senior members are supporting, and students are probably the other side who are getting the benefits of all these sessions.
Yes, but we can congratulate your excellent effort. And I think that you deserve to be specially applauded for taking this initiative and keeping united the students, teachers from all platforms, from all across the country in this journey, because ultimately everyone is benefited in interaction.
I echo his thoughts. Wonderful.
Thank you. Sasi, on to you. Students.
Yeah, thank you, sir. Yeah, thank you, Ashfaq sir and Anirban sir, for your time and input, sir. Thank you, Shiva and Rajesh, for bringing a good case for discussion. Thank you all. Good night. We will close the session.
Good night. Good night.
Thank you. Good night.
Thank you. Thank you all.
Bye-bye.